morning, everybody. I'm Chris Dugmore. I'm the Essex Group coordinator and a volunteer with MDS UK. I'm also the volunteer coordinator. But I offered a little while ago, because I've been to lots of Zoom meetings and so many people were interested in stem cell transplant, that we decided to go right to the top and ask Dr. Victoria Potter from King's to come and talk to us this morning. She is a consultant haematologist and she's the transplant program director. She's been at King's since 2010, and she was estimating that she's probably overseen over 1,000 stem cell transplants, allogeneic stem cell transplants in that time. So she's certainly got a lot of experience that she'll be able to talk about. And she thinks that King's is probably one of the 3 largest transplant centres in the UK. So it'll be King's, UCL and Birmingham are probably the 3 largest centres. So I think without further ado, I will introduce Victoria. I can also let you know that at about 11:45, a clinical nurse specialist called Michelle Kenyon, who many of you may know from the books that she's written about stem cell transplant. They're certainly the required reading if you're going to have a stem cell transplant. So we're very lucky that Michelle will be coming and talk to us. And she now runs a long-term effects clinic for people who've had a stem cell transplant. So she'll be popping in a bit later on. We have some questions that some of you have already written on your registration form. We'll probably go through those first and try and get as many other questions as we can by the method of you raising your hands, but probably we'll let Victoria speak first and then we'll see how the questions go, because I think I'm going to go cross-eyed looking at all these screens and all these hands. So anyway, feel free to give me a nudge. Our operations manager, Debbie Hickman, is here today, and she's going to be my eyes and ears. So hopefully we won't sort of miss anybody. But anyway, I think we've now got how many people in? 33 people in. So that looks good. All right. So Victoria, would you like to start? Got to unmute yourself first of all.
Thank you. Yes, so thank you for the very kind introduction. I thought I would just share a few slides and just raise some of the issues that we think about when we're talking about offering patients a transplant for MDS, perhaps some of the kind of complications and perhaps things that you might want to think about. But I'm going to try and do that relatively briefly because I don't really want to talk all of the time. I want to offer an opportunity for you to ask questions and for this to be a kind of more interactive. So I'm going to start by sharing a screen and let's see how we go. All right. Okay, that looks like it's working to me. Can everybody see? Yeah, okay. So as Chris said, I work at King's. That's in Denmark Hill in London. It's a large place. We do a lot of transplants for MDS and leukemia. It's one of our areas of interest. And I suppose the first thing to think about is actually, why would you be offered a transplant? We know that a transplant's I suppose it's a medically complicated procedure, and it's certainly not without risks. So why might it be an option for you? Now, often people will say, well, a transplant's the only cure for somebody with MDS, and that is definitely a true fact. But that doesn't mean it's the right sort of decision for everybody to make. And sometimes cure is not the best answer. Sometimes managing the disease is better. So when we think about offering people a transplant, fundamentally that depends upon the type of MDS. And we know there's a very large spectrum of MDS. Some are higher risk and some are lower risk. And when we talk about the risk of MDS, what we're really talking about is the risk of that disease becoming a leukemia and therefore becoming a more life-threatening or more acute problem that really kind of needs to be managed. And we work that out based upon a number of features, looking at blood counts, looking at certain cells in the marrow, and a lot about the genetics of the MDS. So that's the first thing. Does the disease or does the MDS warrant being considered for a transplant? Then we have to think about the person in terms of their fitness and whether they would be fit enough to go through the transplant. You can't really have a transplant without a donor. So we definitely need to think about donor availability and whether that's possible. And everybody always asks about age. And so I'm going to say right up front that while we would get worried when people become, say, past the age of 75, up until that point in time, if they're otherwise fit, then we would still consider it. But we would probably do a fairly rigorous assessment of fitness to ascertain that. So I mentioned risk before, and predominantly actually depends upon the genetics of the MDS at the moment. So there's many classification systems, and I'm sure you'll have heard of these. So we started with the IPSS, which had some basic genetic information, and it looked at levels of hemoglobin, and it looked at things called blasts in the bone marrow. And these, for those of you who don't know, are the leukemic precursor type cells. And that can kind of separate people into high risk of becoming leukemia or low risk of becoming leukemia. Then that evolved, and a few years ago, a thing called an IPSS-R was done. Now, this was a revised, the R stands for revised score, which actually had more detailed information upon the genetics. And now in 2020-22, we have a thing called the IPSS-M. And the M stands for molecular. And this is looking at very, very specific genes that we know are important in MDS. So the classification systems have got more complicated. So the traditional models talk about the blast in the bone marrow, the blood counts, the genetics. This includes specific genes. And if you can look at this bottom bit, not to actually really remember any of these, but you can see how complex it is. These are kind of 21 genes. Some confer a slightly good prognosis, some confer bad, and these are all thrown into the mix. And if you have only one mutation, that means more than, say, if you have, that means less than, say, if you have 5. If you have a particular one, that might be more serious than another one. So it's complicated, I think, is the answer to that. And this is basically how patients would kind of fall out. So, based upon these models, you'll have people down here. This is kind of percentage. So 32%, 40% in this very low and low, and kind of smaller numbers of patients in these higher risk groups of patients. And these patients up here, kind of the moderate, high, and very high, are the ones that have higher risk of transplantation to leukemia, who would have a shortened life expectancy from the MDS, and therefore more likely to be considered for stem cell transplant because of that reason. Now, lower risk patients may also be offered a transplant, but if you've got a low risk MDS, then we think we probably need an additional reason. So if you've got a low risk MDS and the blood counts mildly altered and the genetics don't show that this is likely to turn into a leukemia, then we may look at other factors that mean that this low risk MDS might justify transplantation. Now, for some of that might need very regular blood transfusions, because that's obviously a huge impact upon people. If someone was needing regular platelets, that's often very, very problematic. If someone's having weekly platelets, that can indicate even the absence of, kind of genes that we know are risky. That can indicate that this MDS is becoming difficult to treat and may cause problems. And certainly if someone's low blood counts are getting to the point where they're having infections, we know that infections can be risky and life-threatening. So that can be another indication in someone who's otherwise called low risk to actually be thinking about whether a transplant might be an option for them. So the next question is, what's important for good outcomes? So from a disease point of view, we need to get the MDS to be in the best state possible. So it's an MDS where we can see leukemic blasts. We want to get that disease base down to as low as possible. We would aim for kind of less than 5%. A suitable donor needs to be available. And finally, the person needs to be fit enough to have the transplant. So all of these things need to align for the transplant to ultimately be beneficial for the patient. And whilst we may say you definitely need an MDS on the basis of the MDS risk, if somebody's not fit enough, then that transplant becomes not safe for that person. And we try our absolute hardest to make that transplant, which has its risks, as safe as possible. So the question becomes about donor. Now, there is a donor hierarchy. So we first look for a fully matched sibling, because those are the people that are likely to be closest matching to the patient in terms of how the immune systems match up. And that's important. Now, there are caveats to that. If the sibling is fully matched, but they're 80 years of age, we may say, actually, that fully matched sibling may not be as good as a fully matched unrelated donor that's 20 years old. In this day and age, we aim for what's called a 12 out of 12 HLA match. HLA is the word for how we kind of try and type the immune system. So those are our two top donor choices, a fully matched sibling or a fully matched unrelated donor. Now, if you don't have one of those donors, there are alternate donors available, and we can talk about that. But there are other factors, such as CMV, which is a virus that usually we've all been exposed to when we're growing up, and the blood group of the donor that also need to be considered. So we consider a number of factors in terms of choosing the donor. Now, there are alternate donors. So kind of many years ago, we would be worried about these alternate donors. And usually this is what we consider to be less than a fully matched donor. So it could be a 10 out of 12 donor. Now, that's usually still pretty good. But actually, some people won't have an unrelated donor that's considered good enough, and they won't have a sibling. And so then there are two broad categories of alternate donor. One is called a haploidentical, which is a half match. So this is a related donor that is half matched to you. So you can imagine that could be a child, that could be a brother or sister, or that could be a parent. The other source of stem cells, which we can use for transplantation, is from cords. Now, we don't tend to do this very much in MDS because by nature of MDS, it's usually more commonly a condition that's diagnosed in adults and older adults rather than young adults. And there can be difficulties getting the right amount of stem cells from a cord to allow that to be successful, and it can be harder to recover from. So cord these days would be very, very rare to consider in a patient with MDS unless they were otherwise young. But a haploidentical half match who would be an adult will often give a good stem cell dose. And the way we do these transplants has actually evolved so that the worries about previous transplants, like high rates of graft versus host disease or rejecting the transplant, now do not exist. So that is good. The next question people want to ask is, what are the likely outcomes? And the thing to say about this is that it is, again, tricky. Now, these figures here, this starts at 100%, this goes down to 0, and this looks at the survival from the time of transplant. So we can see that unfortunately not everybody survives. And what these different lines are is show you that it's different for people with different types of MDS. And the same sort of genes that say this might be an MDS that is likely to progress to leukemia or likely to cure, some of those genes also mean that the MDS may come back after the transplant. So this is the incidence of MDS coming back, and therefore the disease is harder to cure. So the question about the outcomes from a transplant for MDS are individual, and I would encourage everybody to talk with their medical teams about what the individual risk is for them rather than kind of the overall sort of kind of ballpark figure. So if you were to look at any kind of countrywide outcome, they'll say the overall outcome is about 50%. For some people, it will be better than that, and for some people, the expectation may be that the cure rate is a bit lower than that. So it's really important to kind of think about this in the context of everybody's own individual risks. So if you don't have a full donor, everybody used to say, well, this is probably not going to be as good an outcome. So this is the haplo, so this is the half-matched donor. And what we actually know now is that the donor type is probably less important than disease type. So if you look at all comers, and this is an unrelated donor here, and this is the haplo, you can see here that these lines are the same. So their survival from transplants is exactly the same. And what will determine the people who are up here versus the people down here is not really the donor, but the type of MDS and the type of genetics of that MDS. And this is a recent study. This is the CRBM charts, the American and worldwide registry collects data from transplants, very, very, very large numbers of transplants. So there's thousands of patients in this study. So it's a recent study. And so I think what we can now say really is that an alternate donor is considered very, very safe. The next thing is, will you need treatment prior to transplant? And we can talk a lot about this, but there are very basically two answers. If there's a high risk disease or there's leukemic cells in the bone marrow, likely yes. Remember I said earlier, one of our goals is to make sure we get that MDS into as good a condition as possible before we start the transplant. And so that treatment can be things such as intensive chemotherapy, so very similar approaches to what you would give to somebody who diagnosed with acute leukemia. It can be other therapies like azacitidine, which is, I'm sure, a drug that most of you will have heard of, or newer therapies where you may combine a drug such as venetoclax with azacitidine. So those would be the sort of kind of, I suppose, standard approaches we might think about if we decided somebody needed some treatment. If you've got lower risk disease and the main issue is transfusion dependent, there's no excess blasts or bad genetics, then actually you don't necessarily need any therapy beforehand and you could go straight into the transplant. Because you do, of course, get some chemotherapy as part of the transplant. Another question is about coming into hospital. You know, it's a pretty big deal coming into hospital for a period of time. And for most people, this will be required. And this usually involves having the conditioning, what we call the conditioning for the transplant. Now, that is a combination of chemotherapy drugs to make kind of space in the bone marrow and immunosuppressive drugs that suppress your immune system so that when we give you the stem cells, they're not rejected. So it involves giving that and then a period of time waiting for engraftment, which is the blood counts, to recover after the transplant. And for most people, this is probably around 4 weeks. But I suppose it could be longer, you know, if there were complications or serious infections or other things that we needed to deal with. Some services now offer part of transplant as an outpatient. And so there are a couple of services that are doing this, and we would consider this for people who are otherwise well and who had someone to stay with them, who live within a certain distance of the hospital, or who would stay in a local hotel nearby. And the way we do it here at King's is these people could be offered the conditioning, so the chemotherapy part, as an outpatient, coming in every day to do that and then going home in the evening and then coming back the next day. And then we would usually admit them to the hospital about day 4 or 5 after they have the stem cells, which is when we know they're going to be neutropenic or have a very low blood count. So that is the time then we probably want to monitor them more closely in the hospital. Now, some patients, that's not a great option, but for other people, it's really beneficial. It's more holistic for them. It allows them to be with their family more and to be outside of that hospital environment. Again, that's a really kind of individual decision that people would need to think about on a personal level. There are usually other services within hospitals offering transplantation. So the clinical nurse specialists are really obviously often invaluable as a source of advice, certainly from the disease expert point of view and what you might expect and need to prepare about if you are going into hospital or considering this. We routinely offer everybody an appointment with a counsellor prior to their transplant. And some patients like to take that up when they come in, and some patients just have an initial assessment and decide that it's not of value for them. Many of you will be perhaps asked to see a dietitian or have a physiotherapy review, just in case there are things that can be optimized prior to you coming into that transplant. So it's worth finding out whether these things are going to be valuable to you. The other thing is, you know, what can go wrong with a transplant? Now, I think there are 3 broad things to think about. One is infection. One is this problem called graft versus host disease, which I'll talk about in a second. And another thing is the thing called graft failure. Now, those are direct complications of going in and having the transplant. But also, sadly, for some people, the MDS may actually come back after a transplant. Now, that's not a complication of the transplant itself. That's a problem of having the MDS. So it's worth bearing in mind. Those are the questions that I think you should be asking your kind of medical teams about. So what is graft versus host disease? So we call it GVHD because it's too long to say. And really, this is basically these donor cells. They've worked out that they've been put into a different body. So the donor cells, stem cells, they go to your bone marrow, they give you new stem cells. So therefore you have new white cells, you have new red cells, you have new platelets. This is fantastic. These new stem cells do not have the MDS. However, these new stem cells are also in a body that they've never been in before, and they recognize that body as different, say perhaps as a stranger, and they try and perhaps attack the cells of that body. And that can happen to the skin, can happen to the liver. So skin would be things like skin rashes. If it happens to the gastrointestinal area, then that could be things like diarrhea. It can happen early after the transplant, or it can happen late. And while it's not actually common, because we're quite good at preventing it in the vast majority of people, if you get a serious form of graft versus host disease, it can be very risky for your overall health. And if you have graft versus host disease that lasts a long time after the transplant, that can really affect your quality of life. So it's a really important thing to kind of think about. And the amount of people that would have really bad graft versus host disease affects their quality of life is about 10%. So it's certainly not the vast majority of people, but it's also not zero. The other thing is graft rejection. Now, this is essentially the opposite of graft versus host disease. This is the patient rejecting the donor cells. And what that means is actually the MDS does not get cured, and the person will return to problems of MDS. They're likely to have been through a transplant with no benefit, and actually perhaps they've created some risks of that transplant. So they may have risks of having infections, of having their blood counts below, having been through chemotherapy, but with actually no benefit. It's rare, say less than 5% of people, but it can be potentially a very serious complication. The other thing is infection. Now, when you're coming in for a transplant in the early days after infection, we worry most about bacterial infections. But within the first year, or even after the first year, there are other things that can be worried about. So we worry about fungal, we worry about viral infections. And one of the issues is that when patients are discharged from a transplant, they're often on a lot of medications, and some of these medications are all about preventing these different types of infections. Viral infections are important. We all know about them now, but actually it doesn't just mean COVID. So for anyone having a transplant, other respiratory infections like the flu or RSV or any of the winter respiratory viruses that go around can also be important. And there are viruses such as I sort of alluded before that we may have been exposed to as a young person that didn't cause us any problems because we had a normal immune system. But after a transplant, when that immune system is recovering, some of those viruses actually reactivate and need to be treated. And so CMV and EBV and adenovirus are names of viruses that we would monitor for in the blood and treat if we felt that needed to be treated. So infection is definitely something that we need to monitor for, look for carefully, and treat when we see it. I think increasingly patients that are coming through transplant services may actually be offered clinical trials. And so people are often asking, what about clinical trials? Should I be part of clinical trials? And actually, for the most part, clinical trials are really important for improving care. And sometimes they give us access to new drugs or therapies that wouldn't necessarily be available. I think one of the things to understand is that they may actually not benefit you as the participant directly. If they're offering a new drug, that may definitely benefit, but because we don't know the results of the trial, we could never be definite as to how much benefit that would give you. But they may actually benefit future patients, and in fact, the knowledge would always benefit a future patient. Now, some of the trials will be looking at the actual transplant itself and how that is done. But some other trials might be looking at aspects of supportive care. And when we talk about this, we're thinking about, is that trial looking at, say, what's the best type of preventing a fungal infection? Is this the best way to treat a particular fungus or a particular virus? So, those things will perhaps be talked about. So in the UK, there are 2 transplant trials that are relevant at the moment for people who have MDS. And the UK has started doing trials in recent years when perhaps 10 years ago, these would not have been things that would have been available or being offered. This is called COSI, and it's kind of a complicated side, but basically it's working out what is the best conditioning to offer somebody. Now, these are the names of drugs, FB4 and FB2, and these are very standard transplant approaches for people with MDS. And so this particular trial is actually trying to compare whether the traditional FB4 approach is improved by adding a different drug, which is the T here, that's standing for thiatepa. So it's essentially looking at different drugs in the protocol and trying to understand which of these is actually the best, and does a new approach improve upon what we do as a standard approach. And these two different ones are based upon age. So if you're an older patient over the age of 55, then the doses of the drug should be lowered so that transplant remains safe. The other one is called Amadeus, and this is a trial looking at trying to prevent relapse after a transplant. And actually, that's really what COSY is doing as well. And this is a drug to randomize you to actually take an extra tablet after a transplant. So for some people, that's really not a delightful proposition and they're not interested because they're taking too many already. But this is actually oral azacitidine. So any of you who've had azacitidine would have had a kind of under the skin type injection. There's now an oral tablet that's actually being developed. And so, you know, we worry about MDS coming back after transplant, and there are lots of things. For example, we now know how to do about infection. We now how to deal with GVHD. But treating disease when it comes back after a transplant can actually be quite difficult. So one of the theories is actually, should the focus be on trying to prevent that disease from coming back rather than dealing with it? And so this particular trial is looking at, if we give azacitidine to people after a transplant, does that stop the disease from coming back? There are trials in acute leukemia in people who hadn't had a transplant that demonstrates this to be the case. So we are hopeful that this is a possibility, but, you know, we don't know the answer to that. We won't know the answer to that until that trial is completed. So I think the final thing to talk about, and then maybe we can kind of start asking questions and having a wider discussion, is how do you make decisions about transplants? You know, it's clearly complicated, but I think the first thing is, don't make the decisions alone. And I think, you know, talking to as many people as possible is a good idea. Even health professionals have different way of phrasing things, and some health professionals may be kind of easier to understand than others. You may want to go back for a second or a third conversation about it, because it's really difficult to understand all of the information in one consultation. So going back and making sure that you kind of understand, and things that weren't clear are made clear, is really, really important. It's really important to think about balancing the quality of life versus the transplant. So we can offer you a cure with transplant, but if that cure results in your quality of life deteriorating, then there are definitely people who may say they wish they hadn't actually gone ahead and had a transplant. And that's a really awful thing when that happens for a person. So ask many questions, and I think remember that while transplant is the only cure, it is not the right treatment for everybody. So that's all I was going to say for now. And I think we can perhaps open up to any questions. And it's a comprehensive topic, so I have tried to give you a brief overview of some of the main issues, but there will be areas that I haven't touched upon, and I'm very happy to talk about anything that comes to mind.
Victoria, that was really comprehensive and you know, pitched beautifully. I felt we're all at a different level of understanding about MDS and stem cell, but that was really very clear. Thank you. I've got quite a few questions that have been already submitted when people registered, but when we perhaps move on to people's individual questions, I just want to make it clear, please don't ask Victoria a question, you know, my consultant says this, is this true? Because that puts Victoria in a very difficult, you know, position. So things do need to be kept sort of fairly general, I would say. So one of the questions that was down here, oh, no, sorry, I asked that, better not do that. Are there any steps that can be taken apart from donor selection to reduce, to prevent or reduce the possibility of relapse?
So there are some there are some things that we try to do. So we try to optimize preventing relapse. So one of the reasons that we really want to get the MDS under control. So if there's an excess of blasts or there's poor genetics, we want to get that disease under control. So preventing relapse probably comes across a few steps in the pathway. So the first thing is getting the disease under best control as possible. If there are too many leukemic cells trying to appear, then that disease is harder for the transplant to deal with. So step one is actually optimizing what the MDS looks like before the transplant. Step two is trying to give the best conditioning therapy that we can possible, so optimizing the drugs in that protocol. And we've got an approach, but actually the COSY trial, that's actually one of the things it's actually doing. So we know that giving good doses of chemotherapy drugs will reduce the risk of relapse. So in a younger person, we will probably give higher doses of, say, busulfan, for example. If someone's, older, then that just actually won't be possible and you'll create too much risk for them. The other thing is what you do after the transplant. So in someone that we think has a high risk of the disease coming back after the transplant, we would wean the cyclosporin. So you don't want the person to be on immunosuppression for a very long time. So if there's no evidence of graft versus host disease, our aim would be always to try and by about 3 to 4 months have the cyclosporin coming down and be stopping. We check chimerism, which is the percentage of donor versus the person. And if there aren't enough donor cells, then we would do something called giving a donor lymphocyte infusion, which is not like a transplant, but it's basically just switching that donor so we see the percentage of donor cells coming up. And then the other thing is looking at kind of maintenance strategies. And at the moment, the only one really for MDS is probably an azacitidine approach. And we can't actually do it routinely outside of a clinical trial in the UK.
Thank you. Another question, somebody's saying that 2 years post-transplant and fatigue is still a big feature, and is that normal? Is that something that happens?
Yeah, fatigue is a really, really difficult problem. And I might even be so brave enough to say is I actually think it's one of the hardest things to deal with. It's perhaps more unusual if it persists quite so long as 2 years, but it is a known thing that actually does happen. So I think there are kind of basic things that, we would make sure. So for example, you want to make sure that things like thyroid function or the other medical things that might contribute to fatigue have been actually checked and that they're all still normal, because sometimes they will change after having had a transplant. If your thyroid hormones have become low, then you'll feel fatigued and it won't be to do with the transplant, and actually it's easily fixable. So making sure that there are no medical reasons is a useful first step. And then sometimes it's about actually trying to manage that fatigue. And for some people, that means knowing that if they have a really full day one day, don't plan 3 full days in a row, because they may need some recovery time and all sorts of things like sleep and nutrition. But it can be a really, really difficult and debilitating thing to kind of fix.
Especially coming from a disease where that's, that's what you wanted to get rid of, isn't it?
Get rid of, yeah,
So
exactly.
yeah.
And it doesn't always get rid of the fatigue.
Yeah. Well, thank you for that. I've got some more questions on the chat box. And I think this is similar to a question that I asked and lots of people want to ask was, and you mustn't say kings, how do you choose the best hospital to have a transplant?
So,
But, I think what we're thinking about is, and something I've always wondered, what sort of public domain data is there out, on sort of success rates and, how should patients read them? Because, a hospital may not have a good outcome, but it may be because they're doing the hardest transplants, the most difficult, challenging ones or something. So is there any information out there for patients to sort of help decide if they have a choice?
At the moment, there's not really anything publicly available, but it is an absolute desire of the British Society of Transplantation to actually be able to do that. So what happens for transplant centres is that essentially every year we provide a report to commissioners based upon our outcomes. So the people that commission transplants know what is happening within centres, and they will kind of give you kind of your overall results compared to the rest of the centres. So we get a bit of a view of where we sit. The difficulty is that at the moment, it doesn't quite allow us to outline, is this hospital doing very complicated transplants where you would not expect the outcomes to be good? So I think, Chris, what you're saying is the key to this, that we need to be, in order to understand it, you need to know what type of outcomes that hospital has in relation to the risk profile of the transplants that they're actually doing. So that's an important consideration. And I think within the next few years, we'll definitely be seeing that publicly available. We're also starting to be benchmarked by the EBMT, so that's the European Blood and Marrow Transplant Society. So in the last couple of years, they have started benchmarking centres. And the UK centres look pretty good so far. But again, and they're working also on doing it based upon not just the risk of the disease, but also on what's called the comorbidity index. So this is whether this is basically about the fitness of patients. So there are some centres that may say, look, I'm very particularly worried about this, heart or lung problem, and I don't think this person is fit enough. There may be a different centre that actually says, do you know, we've done this before, we've got some expertise within the heart service here, and they'd be prepared to support this. We will consider, even though this is higher risk, taking this patient through. So the outcomes will depend a bit upon the fitness of the patients as well. So the EBMT is looking at scores where they actually look at all of these things combined. So I think it will come publicly available, and we'll all be able to see what the outcomes are. I think there's also another really important thing in thinking about where you want to have a transplant, and that's the support available to you. So, think about the kind of support from the CNS, think about the follow-up care, think about whether you have to travel 3 hours or 1 hour. At King's, we're a kind of quite a large service, and we do have patients come from kind of all over the country. So one of the things for us is, what is our relationship with that local hospital, because that patient can't come here twice a week after their transplant for blood tests. But actually, if their local hospital is happy to do the blood test and communicate, and you have a very good shared care arrangement, then that's really important. And that will be the same for kind of a lot of you whose transplant centre may not be close to you, kind of understand, the practicalities of you and your care, as well as just a crude figure of what the outcomes might be like.
Yeah, I think years ago when we looked at transplants, we were told it was roughly 1/3 of people came through with no problems. 1/3 of people sadly didn't come through at all, and 1/3 of people had fairly long-term issues afterwards. Has that changed in the last sort of 10? Has that sort of balance changed in the last, sort of since I was diagnosed, which was about 14 years ago? I'm sure lots more are done, and they're a lot more successful. But has that basic balance changed, do you think?
I think the balance has changed and is changing. So I think that, one of the things that is important for outcome is the kind of overall what you call supportive care, so preventing and treating infection. And we have better drugs that treat fungus. We have better drugs that treat infection. So actually that aspect is better. If someone has bad GVHD, I think that's still a problem, and bad GVHD can lead to longer term problems. And we don't have enough treatments for those people with bad GVHD, but we are starting to get more drugs in that area. And certainly, I think what's changed in the transplant space is a lot more things coming through on clinical trials. So, 10 years ago, we didn't have anything to offer our patients unless it was provided directly by the NHS. And now actually we do have other things, which is kind of a huge important. I think we understand a little bit better about the drugs within the transplant as well. So there's a lot of things about the transplant itself that's actually become safe. And I think we're much better about talking about risk. Saying, 1/3, 1/3, 1/3 is very, very broad. But I could probably say to a patient that had particularly high risk disease that perhaps the chance of this working well for you is only about 10 to 20%. And that's, a really different prospect than them thinking that it might be a third with no problems, and would change their decision making about it as well.
Thank you. Somebody's asked a question about treatment with azacitidine. Can it cause a cardiomyopathy? That's a bit out of
it's a bit out of the transplant sphere, but it's very, very rare that azacitidine will do that. So the drugs that we have trouble with from the heart are usually the drug class called anthracycline, which is things called idarubicin and daunorubicin, and they're offered as part of intensive chemotherapy.
Thank you. You probably, I think, covered this. Can people with MDS MPN overlaps have transplants?
Yes, definitely.
Yeah.
Again, you might want to, like, it would depend upon the individual features of that, but absolutely they can.
Yeah. Oh, the donor scoring. You talked about the 12 score. Someone's been advised a possible donor at 9 out of 10 score, and how do the 10 and 12 scores relate? It used to be 10 out of 10, didn't it? And now
it
it's
used to be
gone
10 out of 10,
out
and that's because they've introduced an extra marker. So these things are HLA-A, BC, DQB1, DR, and the new thing is called DPB1, which takes you up to the 12 out of 12. The DPB1 is quite complicated, and it can either increase or slightly decrease your risk of either graft versus host disease or rejection. The most important thing is 10 out of 10. Yep. 12 out of 12 is great, but 10 out of 10 we would still consider a very well matched donor. 9 out of 10 is less well matched, and there is probably a slightly higher risk of graft versus host disease and possibly of rejection, but we would still consider a 9 out of 10 a reasonable donor to proceed with. One of the kind of more interesting questions that people are starting to ask is I talked about alternate donors being half-matched donors. And so there's now a question about, would you choose, if you don't have a kind of a 10 out of 10 or a 12 out of 12, is a 9 out of 10 donor better or worse than that's an unrelated donor than a half-matched haploidentical donor that's related to you? We don't know the definite answer to that question, but that's sort of perhaps where you might be looking at the moment when you're considering donors. So if that came up for a patient of ours and we had a 9 out of 10 and we had a haplo, and say the 9 out of 10 donor was 50 and the haplo was 21, and the 9 out of 10 was CMV mismatched and blood group mismatched, but the haplo donor was blood group matched and had the same CMV type, then you might well be saying, actually, that haplo looks better, not just because of that actually matching thing, because of the entirety of the characteristics of that donor.
And one of our very long-term MDS members actually had 3 stem cell transplants, and the first 2 were unsuccessful, but the final one was a haplo one from his son, and he's been running marathons ever since. So
yeah, I think I know that person.
Yeah, we all know that person. But and his son's gone on to do medicine, which is really interesting. But
it's extremely good. I mean, and that transplant would have happened when we weren't so confident and there hadn't been so many haplos done, particularly in kind of MDS.
So this was, yes, as you say, this was quite a number of years ago, at least 10 years ago. So and we've just heard from one of our members that he's been not so lucky getting a donor, but is happily going to go ahead with a haplo from his son as well. So it's definitely happening and on the increase now, which is good.
Yeah, and it's certainly, the one thing we can say that it is safe, and the rates of graft versus host disease do not appear to be too high. So these are all very, very reassuring things that we are learning over time.
I think this question might be about sort of how long is a piece of string, but is it possible to say what the increase in life expectancy is from having a transplant? I suppose you would say that depends on how successful it's been.
Yeah, it depends upon how successful it's been and the disease risk. So, for example, someone who's, and this is a rare group of people, if you're in the group of people that have very, very high risk MDS and your life expectancy without treatment is probably less than a year in that situation, then you're almost certainly, if the transplant is successful and the disease doesn't come back within the first few months, will gain kind of life expectancy from that. And if that transplant is successful and you don't relapse in the long term, you'll have probably gained many, many years.
Mm.
Now, it's different in lower risk MDS when, say, for example, the main issue is not that it's going to turn into leukemia, but that a person is very transfusion dependent. And they may be okay for a number of years on transfusion, or they may proceed to a stem cell transplant and suffer a very severe complication of the transplant and perhaps die from a complication of that transplant within 6 months of that transplant. And in that situation, there's a risk that their life may have actually been shortened. And so actually for some people with the lower risk MDS, it's sometimes actually it's a much harder decision to actually make about going ahead with a transplant because of, you know, that risk. If, even though these things are actually very, very rare, but if that happened to that person, then clearly that's, you know, not a good outcome for them. So it's much easier in higher risk disease to say that someone is likely to gain in life expectancy.
Thank you. A comment made about choosing a transplant hospital. It's a very good point about you know, how far away from home it is, because when you have all the follow-up visits and you don't feel like traveling, and if, you know, as with COVID, there are risks to traveling post-transplant, you know, it's worth thinking about if you can get somewhere nearer to you. And also, I mean, obviously you don't have heaps of visitors, but you do get occasional visitors, and it makes it easier for family to visit when you're able to receive visitors. If
Yeah, it's a
it's not,
really, really important point.
yeah. And I think actually at King's and possibly other centres, I think you have accommodation, do you, available so that people can live quite near King's in the early weeks, so that if they're coming in for checks that they can, you know, not be
Yeah,
too far away.
I mean, at King's it's very, very difficult because there's not a lot of accommodation around. And we have some provision, but we actually don't have a lot of it. So most of our, so if somebody came from kind of very far away, we would usually ask them to stay nearby for the first 2 to 3 months. But for someone who lives 2 to 3 hours away, and I suppose for us, Eastbourne on the coast is a typical example where someone would have to travel 3 hours to come to King's. We would see them maps in the early stages once every 2 weeks, and then their local hospital will be taking their bloods and sending to us, and we will be doing a lot of communication with the local hospital. So I think there are kind of different arrangements, but these are the kind of questions that I think are really important to ask, because it helps you kind of make a decision about,
Mm,
you know, what you can have close to home and what's not possible close to home. But
thank you.
it's really tricky because often the intensity of follow-up comes at the time when you're most tired and
Mm,
you've just had the transplant, and you know that definitely makes it tricky.
yeah. All these things need to, you know, need to take them into account, don't you?
Yeah.
Somebody who said that they're in remission from I presume multiple myeloma, and will this affect whether they qualify for a bone marrow transplant for MDS, which presumably they have now?
No, it wouldn't.
No.
So you would, in that scenario, so if that was me and we had somebody come and they'd had multiple myeloma and they're in remission, we would say fine, but we would be finding out from their myeloma doctors what that would mean for myeloma treatment afterwards. So it may be that they may need some other myeloma therapy, and so you'd have to reevaluate all of that again. But we have had, you know, a few patients that have had MDS and perhaps CLL, or MDS and AML and myeloma. So it does not disqualify you if you otherwise need it.
Um, got a nice question here from Mark. He's got a couple of potential matches in his family, and he wondered if you could talk a bit briefly about the sort of process that they would have to go through in order to donate their stem cells.
Yeah.
Yeah.
So we would most commonly do get stem cells from the peripheral blood. So there are two ways to get stem cells out of a patient. One is to do a bone marrow harvest. And for that, that means the patient goes to theatre, the donor, rather not the patient, goes to theatre, has a general anaesthetic, and essentially has a bone marrow needle stuck into their pelvis multiple times and the stem cells sucked directly out. So they're asleep and they're having a general anaesthetic, but it's not actually, I think, the nicest of procedures. So the vast majority of centres use peripheral blood stem cells for transplantation. And there's some advantages of that because you tend to get a better stem cell dose as well. Now, the process in that scenario for the donor is that they have GCSF injections. I don't know how many of you have come across GCSF injections, but for those of you who haven't, they are injections that stimulate the stem cells to come out of the bone marrow. The injection gets given under the skin, and they stimulate the stem cells to go out of the bone marrow and that, so that there are more of them circulating around in the blood. And those stem cells are then collected by like an apheresis machine or a cell collection machine. It looks a bit like a dialysis machine. So there's a vein in one arm and a vein in the other, and it takes about 3 to 4 hours to collect the cells. So the donor will get 4 days of these injections leading up to a day when the stem cells were collected, and they would have to sit there for 3 to 4 hours whilst those cells were collected. They would have to have a medical as well. So they'd get a formal medical by a doctor who would look at all of their medical history, do a series of blood tests. And the aim of that is, one, to make sure that there are no issues with the donor that means that they couldn't donate to you. Say, for example, and this is very rare, we don't really see this, you checked a donor's blood and they had HIV. Well, suddenly that donor is not going to be suitable because that creates a risk to the patient. You may find that the donor has rheumatoid arthritis. We don't use donors with autoimmune diseases to be donors. So you may actually find that the donor has, a heart condition or something that, perhaps somebody didn't know about, in which case you may put the donor at risk. So the aims of the donor medical are two. One is to make sure the donor's fit enough and that we do not risk the donor's health in any way by them being a donor. And two is to make sure the donor has no health conditions that could actually create a risk for the patient who is receiving those stem cells. People ask, particularly when it's family, is there a risk of GCSF causing leukemia in donors? And the answer to that has been lots and lots and lots of studies, and the answer to that is essentially no. That we've been doing kind of donor collections from family members for years. The world's been doing it for years. And so there's this thing called the World Marrow Donor Registry, which actually looks at all of this information. And the risk in donors who receive stem cells is not above that of the general population.
I wondered as well, because some people have mentioned it, about especially for, related donors, if the transplant isn't successful, how they feel about it. And I wondered if there was any kind of sort of counselling for people who are donating to sort of help them think through sort of the implications, or if that isn't anything that happens. Because I have heard of people where it didn't work who felt terribly guilty about it, and it's
I think
fault,
that's really, really true. And the other scenario where people might feel guilty is if the person they donated to ended up with quite bad graft-versus-host disease.
Yeah.
That can make somebody feel guilty. So when the donor is consented, they have to have a fairly lengthy consent process. That is brought up as one of the discussion points. Now, obviously, the people who are doing consents, that's the kind of medical team. It's not the same as an official counsellor who would be, an expert in kind of counselling. So, I mean, here we're very lucky at King's because we have about 3 counsellors. So we've got the ability, when there are issues or particular concerns, to actually offer different counsellors to the patient and the donor to help support people through that. Now, that's not available everywhere, but sometimes these services are available via things like Macmillan or whatever the local thing is, or the local issue. So I think, it's up to, I suppose, us as medical professors and nursing staff to make sure that we've explored those issues. But from the patient perspective, if there are particular concerns, any help you can bring in raising that to kind of your medical nursing teams or people who work here is actually really, really helpful, because if we know about it, we've probably got something that we can offer to help. But if we don't quite kind of know about it or appreciate that it might be an issue, then help may not be offered when it's available. So I think, as much kind of talking about that as possible.
Yes, and I have to say we've got somebody on the call, and we might get a chance to ask him to speak. But he had two sibling possibilities, and he's come through the transplant very well. So now he's actually got a favourite sibling. So I don't know how you can
Well, that's that. I
you
mean,
know.
yeah, I mean, we get loads of people who are like devastated as well if they don't turn out to be a match. So
Yeah.
that can actually be just as hard as being a match and something kind of not working. But yeah.
Yes, and it's a strange thing with matches, isn't it? Because when I was my brother and sister were tissue typed, I'd have put a lot of money on my sister being the match, but it was my brother, so he drew the short straw sort of thing. So
People do like to guess, and they think, oh, if I look like them more than the
yeah,
other one, then it might be that. It just doesn't seem
yes.
to work like that.
Well, I've told my sister that my mum had a different milkman then, so that's really helped. But yeah, now we've got another question. Is there any data on COVID-related mortality of post-transplant patients who are obviously sort of quite a high risk group? And if yes, where is that data? That's the million-dollar question, isn't it?
It is a million-dollar question. So when the COVID pandemic first started, we were incredibly worried about our transplant patients, and certainly the risk in patients had a transplant of dying from COVID was higher. And we unfortunately did see people within our service who passed away because of COVID, and that was very early days, and people were catching it, and at the time when there was absolutely no therapy available. So as a general rule, the risks of running into a problem from COVID are worse if you are closer to the transplant, because that's when you're most immunosuppressed, are worse if you're on high levels of immune suppression, are worse if you've got graft versus host disease or other problems from the transplant. If you are 5 to 10 years out of the transplant, your risk of having a significant from COVID is probably not very different to the general population. If you're 3 years out of transplant, that's good. But if you're still having immunosuppression because you've got ongoing GVHD, then your risk is much more similar to somebody who's just had a transplant. So it depends a little bit upon how close you are to the transplant, whether you're needing any additional therapy for either graft versus host disease or to treat an MDS, say, perhaps trying to come back. The bit that is really tricky with understanding all of this data is that we know that COVID is evolving and that there are many variants and it evolves over time. We also have been very fortunate to actually have some therapies for COVID now and an ability to deliver these therapies relatively quickly. And and vaccination is also changing how risky it is for patients. It doesn't mean that we don't worry about it, but I think giving exact figures, at the moment is a little bit difficult. It's not a particularly helpful answer, I'm afraid. But I do think the only reassuring thing is that we have vaccines, we have new therapies. The upsetting thing that everybody would know about, that many people are upset about, is the Evishield news, where that does not look like that was going to be funded for people who didn't have an immune response. And most medical professionals, and you'll have seen the blood cancer charities that have all been campaigning very, very hard at the government level to try and make some headway, but those efforts have not.
And sadly, we had to campaign very, very hard to make sure that we got included in the data set for the COVID treatments.
Yeah.
Because due to a computer says no type error, MDS and CMML did not get included, and people weren't told that they were eligible for COVID treatments. And of course, if you don't know you're eligible, you don't know what to push for. And also the fact that it should have been an automated process and not rely on people having to advocate for their own treatment. So hopefully we've got that sorted. But yes, certainly Evusheld is a big sort of disappointment for people who are immunosuppressed, which is obviously blood cancer patients and a lot of people, kidney transplant patients, etc. So yeah, it's very, very disappointing. Someone asked whether what determines whether you have the donation through the bone marrow or the stem cell, the peripheral blood. And I would imagine that most people would go for the.
Most people go. So usually the donor would be discussed. Sometimes donors are worried about having the GCSF injection, and we would explain to them that actually the differences between having an injection versus going to theatre and having a general anaesthetic. And I think once people actually think about the detail of that, most people want to opt for having it done via the blood collection way. There is perhaps a slightly higher risk of graft versus host disease than if you with peripheral blood, because the stem cell dose is higher than with giving it from the bone marrow. But that's overcome by the fact that you get a better stem cell dose, and that's better for engraftment. So in a disease such as aplastic anemia, where you really want to do your best to minimize graft versus host disease, in America, they will always try and opt for bone marrow for the donor. We would not do that because we've got a very effective way of preventing graft versus host disease and a very good protocol in the UK for patients with aplastic anemia where they all get Campath, and that's very good in that particular scenario. So here, the only reason that someone would donate bone marrow is if we thought that they couldn't actually donate peripheral blood cells. And so if they had terrible veins and we knew that putting them on the machine, because you need their access to be good, and that say putting a central line in, which is the other way you can get it if their access through their kind of arms isn't great, wouldn't work, then you may do a bone marrow harvest if you thought you couldn't get them that way. But I actually cannot think of the last time that we ever did that we ever needed to do that for a donor.
And I think all of us who've had a bone marrow biopsy would be sympathetic with our relatives or donors not having that, because you do feel like you've been kicked by a horse afterwards. So
yeah.
I think that's a question which is a bit sort of individual. Returning to the question about azacitidine and cardiomyopathy, but interestingly, the person says that the patient had COVID as well, so I'm sure that couldn't be ruled out as a cause of it, but we would be very speculative about it, I think.
Yeah, I mean, it's worth having a conversation with your local hematologist. Well, he'll understand the specifics of the case. I would be surprised, and COVID obviously also has many, many other side effects as well, and you'd have to think about the timing of the COVID in relation to the cardiomyopathy and whether that was also contributing. So yeah, there'd be lots to kind of work out to try and understand it.
And some vaccines, that's also been an issue. I think the AstraZeneca one for younger people did have an issue. So getting to the root of it, I think, would be tricky. Yes, and this is probably a question I'd ask, but how ill do people typically feel during and after the transplant, and for how long? And I think, again, this is somebody that, we see lots of people in our MDS group who've had any number of bouts of sepsis, which is, hospital treated and not very pleasant, and are feeling very, very ill with their MDS. And so sometimes possibly that decision to go for transplant is easier. But people who feel well, it's hard to go from feeling well to putting yourself in the position. So it's a bit difficult to know, I suppose, how you feel. And I think it is variable. But maybe the answer to that question would be when we ask people who've had transplants to be honest about what it was like, because they've had the experience.
Yeah. I mean, and the other thing is it is really different for everybody. And We can counsel you and talk about all the things that might go wrong. They won't all happen to you. Some of them might happen, none of them might happen. We can not necessarily very good at predicting that it will definitely happen to you or it won't. So there's a little bit, but sometimes you can have a person who you think may have a lot of complications because you're worried about some prior aspect of their health that's not related to MDS, and they will sail through it. And the opposite can also happen, that a really fit young person will get a very unusual, unexpected infection, and they will unfortunately feel, unwell. It's a if you're kind of feeling very well and then you go through a transplant, you're admitted to hospital, you're having drugs, you go out of hospital, you're taking a lot of medications, you may feel worse before you get better. If you're a really fit patient, you may actually tolerate it really well. It is a bit like one of a piece of string kind of questions. It's very, very variable. So I think talking to people who had transplants themselves is probably a really good thing. And when people who have had transplants go home, they're often tired, and that tiredness can often be worse than the tiredness people experience after chemotherapy. So there are a few little kind of things, and I would tell people to have 6 months to a year off after work, if that's any kind of indication. And that's not because you'll feel unwell all of the time. Sometimes that's because we're demanding that you come back to hospital, or we're managing this, that, or the other. But to allow yourself time to recover and to focus on yourself, I think is really important.
I think, and Fiona's answered that, so that's lovely. I did invite a few people along who've had transplants, and mainly I think they've had sort of quite positive experiences, but maybe if I could just ask them to be ever so brief, because it may be that Michelle may be popping in soon. So if you could, if when I do invite you, if you could just be sort of very brief about, maybe how old you were, how you're feeling now, any complications you had. Would that be okay? Okay, I'll go now to Barbara.
Hello.
Hi, Barbara.
Yes, I had my transplant 4 years ago, and it went very smoothly. It was very strange. So I don't think I'm typical. When I had mine done at King's, and while I was an inpatient, I was getting up at the morning 7 o'clock and sitting in the chair. I was never confined to my bed feeling too ill to go through everything. And the doctor seemed to think that was unusual. I was very lucky. When I came out of hospital and I was doing my regular visits back outpatients, they warned you, bring in overnight things in case we keep you in. And that happened to me. I had to come in for about 10 days because I was having a little bit of sort of diarrhea reactions. And apart from that, touch wood, I have been fine. I had a German donor found for me by Anthony Nolan, so it wasn't a relative at all. So
what was the state of your MDS when you had the transplant? Were you
I was
high risk?
I think I must have been fairly low risk, but I was having the bloods like every week.
Right. So your transfusion load burden was quite high.
It was really odd. I had a look yesterday at my notes because it was February 4 years ago. All of a sudden, I got really extreme fatigue, and then after that, I was having the bloods. It seemed to come on very quickly.
So you're a poster girl for successful transplant. So
I think I'm unusual because I can remember the doctors coming in my room at King's saying, "Oh, you're sitting up doing a crossword," and because we were warned there will be days when you just want to lie in bed in the hospital because you feel so rough. And I don't know what went wrong or what right, but it never happened.
It went right for you.
I think that so we probably err on the side of warning people that things may be harder. But with you, it was probably it's the kind of lower intensity of chemotherapy that we were able to give, and those are exactly the sort of patients that people that can also have an outpatient transplant. So we kind of have started to identify some people who will feel well enough to be out of hospital. And I have to say, when someone's sitting and doing a crossword, I think it's always great because, you know, if while you're in the hospital having transplants, you get out of your bed and you sit in the chair, they're tiny little things, but I think that they kind of help a little bit when people can do those.
Yeah. Fiona, could you tell us about yours?
Okay. So I was 54 when I had my transplant, and that's almost exactly 2 years ago on the 1st of September this year. And I was low risk MDS, 5q minus, but I had some genetic mutations, TP53 being one of them. And I'd had MDS for 23 years, so just ticked along. And I was on lenalidomide, which is a well-known MDS drug, and I was on that for about 13 years, which is quite exceptional as well. Things just started to change a little bit, I think, and they sort of started to talk more seriously about transplant. And again, it's one of those things, you feel okay because you're on a, you know, you're young and you feel fit and well-ish. And then you've got to decide whether to put yourself through all of that. So we did make the decision, we did go through with it. And my big bits of advice would be, yeah, the hospital is a factor when you come out because you just really don't even want to leave the house. So if you've got a really long journey, then that's difficult. So I live in the West Midlands. I was being treated by my local hospital, but coming down to King's once or twice a year. And then I think because I knew a transplant would be inevitable at some point, I did make the decision to transfer my Centre of Excellence care to the Queen Elizabeth Hospital in Birmingham, because that's nearer to where I live. And I think that was a good decision for me because it's only 40 minutes from where I live. And I know I couldn't have coped with the journey down to King's regularly because of the distance. So that was good.
So what's your situation now then?
My transplant hasn't worked, unfortunately. They have said to me that I do still have MDS and I still have the genetic mutations that I had. So that's a bit frustrating because I feel back to where I was before, but they are hopeful that it may have done something. I did have 4 DLIs afterwards as well, which is the sort of top up, and no real problems with graft versus host. So I think at the moment I'm in a stable position. So my blood counts aren't normal, but they're normal enough for me to live quite happily and normally doing what I'm doing, with some help from antibiotics and GCSF injections. They're hoping that although the transplant hasn't necessarily cured me, it may have slowed things down, or it may have changed the disease in a way we don't know yet. And interestingly, when I had my last appointment, my chimerism has suddenly, out of the blue, started to go up. So my donor cells are increasing again. So I don't know, maybe I'm just a slow burner.
I would never say that about you, Fiona. Thank you for that. David Richardson.
Hi, good morning.
Hi, yeah.
Yes, I was diagnosed in 2018, and I was on the AML trial, which seriously compromised my health. So I was prepared for transplant with acetidine, and I was transplanted at Churchill, and my twin brother was my donor. So
your favourite brother. Your favourite brother.
The other brother's all right as well,
Yeah.
but he was a bit scared to do it, so he was second choice. But yes, I was, as people have said, I felt quite. I had I was at Churchill, but I was ambulatory care, so I was staying on the site, and then went over every morning for the chemo, and then had the transplant. And they took me into the ward, and I must admit, I felt really ill for 4 days afterwards. I didn't want to do anything. It was as much as I could do to open my eyes. And then one morning I just thought, wow, I jumped out of bed, had a shower, got dressed in my outdoor clothes, sat in a chair. My girlfriend came to see me, and we chatted. The doctors came in and said, "Oh, you can go home tomorrow." And off I went. And then I just had to keep going back and forth. I did have GVHD. I had quite a bad dose in my liver, which caused quite a concern, but steroids and things like that seemed to sort it out, because it was coming up to Christmas in 2019, and they were umming and ahhing about bringing me in, and I didn't really want to go in, but they let me out. And so now, 3.5 years post-transplant, my biggest problem is fatigue, but I have another problem which was before or after the MDS. I don't really know. Nobody seems to know, but yeah. I was told originally that because I'd got RAB2 high risk, and they basically said transplant or nothing. So it is a decision to make, and you've got to bear in mind all the factors. But in my case, there was no choice, I don't think, and so I'm glad I went with it.
Good.
Yeah, I would say, you've got to grasp it by the horns, and you do what's good for you and for your family in that.
Thank you. Yeah, thank you, David. And I'm sorry about your unfavourite brother.
Yeah, he's all right.
He's all right.
Yeah.
And Stephen, any chance? No? Can't hear. Nicola, I asked you to come along as well, didn't I? Thank you.
Yeah, I only had my transplant in January, and I had MDS EB2. I was diagnosed at the end of July, beginning of August last year, and they just said to me that transplant is my only option. And I was happy to go along with any treatment because I just wanted to live. But it wasn't until I signed the consent papers that I actually realised how bad it was. And they said without the treatment, I'd have had maximum 9 months to live. So the actual, I was in the Hallamshire Hospital in Sheffield for 6 weeks. So out of the people who had transplants the same week and the same day as me, I was in the longest. But I was really poorly with the transplant. I had kidney failure and liver failure. But the worst thing, I just ballooned. I put something like 23 kilos on in water. I just ballooned. And that's what they were really concerned about. But since I've come out of hospital, I've been doing amazingly well, really. I've just had one episode back in where I got para-influenza. But I'm, depending on when I go, I'm either 99% or 100% donor. So I'm doing quite well from that point of view. But I have noticed when I get infected, I've got an ear infection at the moment, it's taken me 3 or 4 times longer to get over things. I've been back to the doctors today because I've had 2 lot of antibiotics to clear this ear infection, and it's still not cleared. But I feel okay, and it's a bit strange because the transplant now feels a bit like an out-of-body experience. Really. And if you'd have asked me the day I came out, would I have another one? The answer would have been no. But because I actually feel quite normal, and sometimes I feel a bit of a fraud because I'm not allowed to go to work, and I'm not allowed to do this, and I'm not allowed to do that. But I actually feel okay. But if it does fail, I know it can fail at any point. And I've always got that at the back of my mind. I'd definitely go for another. If I was eligible, but I had an unrelated donor, a 10-10 match. So some nice young man, 38-year-old in the UK, donated his cells, for me.
Yeah, thank you, Nicola. And I'm glad to hear you're feeling a lot better. I think last time we met that you had quite a few issues, so it's good to see you so well. It's lovely. Michelle has arrived. Michelle, thank you very much for coming in.
Thank you.
I've already bigged you up, but I'm going to big you up again about just so that everybody knows this is the Michelle Kenyon. That's probably, I can probably say that kind of, and you've probably, all of you have had a transplant, probably, you know, did read her books. It's sort of part of the process, isn't it, to find out what's going to happen. And I always tell people, don't just read the book about when it's going to happen, read the book about after it's going to happen, and then that'll help you, you know, with making your decisions so that you're fully informed. So we're really glad to have you here, Michelle. We're just Victoria's just given us a lovely overview of everything to do with stem cell transplants. And I wonder if you just wanted to say a bit about your role, because Victoria says you're now in charge of a long-term effects clinic. And I wonder, could you tell us a little bit about that and your work there?
Yes, absolutely. Thanks so much. And thank you for inviting me to be part of the meeting today. Absolutely delighted. Yes, the long-term follow-up clinic. In fact, that's where I've just come from this morning. So I've managed to shuffle some people around and sneak away, leaving my colleague with the rest of the clinic, who's very capable. So I mean, if I just tell you a little bit about me, and I've actually had various roles while I've been at King's. Been at King's quite a long time, about 20 years now. And I started out life here as a transplant coordinator, and that's when the sort of 7 Steps book sort of evolved really from that. And then we recognised that it was really important to devote just as much time to looking after people before the transplant and getting them safely to the point of being admitted to hospital. And it was also important to be able to offer that same level of support to people after they'd had the transplant and during the recovery phase, which for many people is an ongoing project, really. It's not something that kind of has a very defined beginning and end. And now, and subsequently to that, as part of that work, we also recognised that an area that we could really improve on was where we were looking after people long term, people who are in that sort of time zone post transplant. Often have slightly different things that they want to talk about when they come to clinic, and their needs are slightly different. So we created probably one of the first clinics in the country really to kind of incorporate a sort of dedicated service with having the time and the space to cover not just the out of that appointment, because there's so much stuff to talk about. People come to that clinic once a year, and we sort of go through a sort of clinical assessment that is based on the international guidelines for long-term care for people who have transplants. But we also make sure we also have a bit of time to talk about how people are actually getting on in their lives. And, you know, what I've learned as time has gone on is that people's lives after transplant are very dynamic, and recovery, apart from not being a kind of linear process, is very much influenced by the normal things that happen in life, like work or education, or being ill with other things. And so it's been great really to be part of that and help to deliver that service. But also it's been a real joy to see people actually very well post-transplant and thriving and growing and developing new goals in life. So it's been great.
We've got a couple of our MDS key people that I'm sure you'll be very familiar with, but you know, who have, you know, very long-term problems following transplant. And for one of them, certainly, she's endured sort of quite a lot of damage to other parts of her body through the transplant. You know, hearing, stomach, you know, the list sort of could go on. So, do you find that you know, you have quite a lot of people in those clinics, or is it quite rare for people to be, you know, long-term affected?
So it's very variable, the degree to which people can develop long-term complications. I would say, and I think Victoria would also agree, that the number of people who have multiple significant problems many years after transplant are quite small in number. So the majority of people who do have problems, there'll be problems that in the main are kind of can be incorporated within a normal life. When people develop long-term chronic graft versus host disease, and we have quite a few patients with long-term chronic graft versus host disease in the long-term clinic. You know, again, we have some patients who have flares of that chronic graft versus host disease and may require occasional hospitalizations. But again, those aren't, in this particular clinic, those aren't that many. Most people who are 5 and 10 years out post-transplant who have problems with chronic graft versus host disease will be spending most of their time out of hospital. Some of them being able to accommodate the demands of the graft versus host disease with a relatively normal everyday life. Some people will be much more affected than that and will have quite disabling experience as a result of their chronic graft versus host disease.
I just thought of a question earlier, probably for either Victoria or you, and that is when a transplant is deemed to have failed. A few years ago, there was a policy decision within the NHS not to offer second transplants to people who had failed, or I shouldn't say the people have failed, that always sounds like it's their fault, doesn't it? The transplant had failed. And sadly, you know, one of our members was denied a second transplant and died as a result. But we're hearing, and there's certainly somebody on this call, and maybe I'll ask her to talk in a minute, of people who are being offered second transplants after a previous one has failed, with differing results. But I wonder what the policy is now. Maybe Victoria, you could answer that, and then I'll pass you over to a patient who is just recovering from a second one.
So the policy has changed, but before I get onto that, I want to kind of thank all of the patients who have actually been speaking. It's really kind of lovely kind of hearing your experience, and I think it really emphasizes the different experiences people can have and how individual it is for everybody. So in terms of transplants, there was a policy where second transplants were not allowed. And this is in the very specific instance if the disease comes back. So if the disease relapses after the transplant, say the MDS comes back, that was not allowed. If the person didn't engraft, we've always been able to do a second transplant if the counts didn't recover, to kind of rescue them from that. So that's one situation where we've always been able to do it. The current policy for that relapse situation is if that relapse occurs within the first year of a transplant, it is not funded by the NHS. And that's really because if the disease comes back within the first year after transplant, it is highly unlikely that doing a second transplant would cure them in the longer term. So it's decisions being based upon what the kind of available evidence is. Now, obviously, there are exceptions to every rule, but that's the kind of constraint we work in. So you're absolutely right. There was a period of time where some people who would now have been eligible would have actually missed out. And it's good that that has now changed for the better.
So yeah, thank you for that. So that sort of sets out the options, that people might have afterwards. So basically, if it fails within the first year, then that won't be funded. But if it fails because they didn't engraft in the first place, or if it fails at a later stage, then they can have another one, and that's good. All right. So can I hand over to Karen then, because
Hello.
Hiya, Karen.
Yeah, it's interesting. That's just reminded me, actually. So I was diagnosed with MDS in 2018, and initially it was low risk. And then after genetics testing, I ended up with 5 mutations, and which had changed then obviously to high risk. And that was how I got introduced to Professor Mufti and over to King's. So I had a year where I felt okay, still working. I'm a nurse as well. So I had moved house as well. So it was just a bit tired, but apart from lots of bruises, but apart from that, nothing really. And then I think it was the April 19, I saw Professor Mufti and he immediately said stem cell transplant. But unfortunately, it transferred to AML in May 19. And I had a very tough time with CPX chemo and ended up in Belfast. So I'm in Belfast as well for about 19 weeks. Ended up with cardiomyopathy as a result of that. So the transplant had been hoped for a few times that summer, but didn't actually happen until November 19. So we made the decision that I would do it as an ambulatory patient. My sister came over with me, and we were in a very wacky hotel because the King's, as we weren't aware that there was any accommodation, we're told there wasn't. But so anyway, I did mine as an ambulatory patient, basically sailed through that, except for a couple of days of chemo-induced temperatures. Admitted for a few days and came out, and I felt absolutely fine. I thought, this is great. Yes, I felt a bit tired, but I felt fine. I was able to walk to and from King's every day. So I felt very, very relieved. And I actually got home 4 days before Christmas, cooked Christmas dinner for everybody. Was amazed by all of this. And unfortunately then, one of my bone marrow biopsies showed that the chimerism was falling. So we did the next one, and then it had fallen quite considerably. So I was due to have a DLI, lymphocyte infusion, on the 14th of April. And unfortunately, COVID had kicked in. So the donor then declined to donate. And as a preventative measure, I was started on azacitidine injections. The donor continued to decline to donate. I think it was the August of that year. By which stage I think my disease had tried to come back again. Although I was on azacitidine for 18 cycles, felt great, and I thought I couldn't imagine feeling. I felt so well that I thought it's as if the transplant has worked. So that was fine. Unfortunately, I think it was last year. Oh, my MDS had then changed to CMML. And so sort of goalpost changed a little bit. And so we're talking about a second transplant. So COVID maybe did me a little bit of a favor, because while the graft hadn't been successful, the time it took to get things going again, my year had gone or had lapsed. So all set up for a second transplant, 18 cycles of azacitidine, all set to go, got the call, all set to go, bone marrow biopsy, and unfortunately the blasts were too high. So I was brought into City Hospital in Belfast and had more chemo. That was the November of last year. And so I had chemo, I was in there for 6 weeks before Christmas, home for a couple of weeks at Christmas, in after Christmas, and again, all set to go, hopefully early March, when the blast cells were still too high. So I was started on gilteritinib, obviously devastated at not getting over for the stem cell transplant. I was on gilteritinib for 2 months, I think, which amazingly, and it's wonderful, brought the blast cells down enough to go over to King's again. So I was all set to go. The difficulty this time was trying to get hotels booked, because it was just a complete nightmare. But anyway, we managed. My sister, because of visiting, she couldn't stay. And so I was very much on my own, and sailed through the first few days of chemo. And then I felt as though I'd been hit by a sledgehammer with one of them. So I felt very ill for a few days, had my stem cells on the 27th of May. And that was okay. I had a bit of a rough time after that. Again, I think I can't even remember. There were about 5 days, 5 or 6 days. I can't remember very much about it. But I did feel a bit grim. I was spiking temperatures again, which we didn't know what was being called or what was causing them. So my experience so far had been completely different from the first experience. I was then discharged. I still didn't feel particularly well. Discharged and came back from my visit on the Tuesday following that, only to almost collapse at the front door of King's and felt really, really ill. But I developed graft versus host disease all on my skin and spent very uncomfortable time back in again, trying to get that sorted out. So we're on top of it at the minute, and it was great with prednisolone and cyclosporine, loads of medication. It just feels like a lot more this time. But it has really taken it out of me this time, whereas before I didn't feel, although it was unsuccessful, I knew I'd been through something, but this time it's just been a totally different experience, exhausting. I've had a little bit of a flare up of GVHD, which is, that's why I keep scratching, so sorry about that. And I feel like sort of scratching all the time. But things are settling, and I've had 2 biopsies, and amazingly, both of them have been 100%. Chimerisms have been 100%. No MRD, sorry, no disease. And I'm due to have my 3rd biopsy, I think it's the 5th of September, which, oh, yes, 5th of September is my 100 days. So I think it's the next day, and get the chimerism bloods done next week. So please, everybody, fingers crossed. But totally different experiences, you know. It's been so hard. At the same time, with the GVHD, I feel hopefully something is going well. The first time I had no GVHD, no symptoms of anything, which I thought, I knew myself that this isn't as good a sign, isn't a good sign. But while it was great to feel well, so it's been a day by day, just, you know, one day at a time. And sometimes it feels like a step forward and 2 steps back, but I'm very determined. I'm trying to walk myself back to fitness again. And oh, it's just, I am so grateful that I got the second transplant. I would have said about 2 weeks after transplant, I will never, ever go through that again. I hope I don't have to. But I think if I did, and it was allowed, I probably would, because I just want to grasp at life. I just have, I won't give up, you know. So I feel good today. As you see, my granddaughter.
That's good. And you know, Karen's experience is, you know, quite unusual in as much as, you know, having to have 2 transplants and all the complications that that you had that kept sort of stopping it happening. So. Yeah, we're grateful to you for sort of sharing that, and for sort of knowing that the second one is possible. And it's just interesting, isn't it, how the same person can have the same procedure and have such very different, you know, experiences. I mean, Michelle, have you got any observations on that? Have you seen people who've had 2 transplants? Or
yeah, I think no. I think, you know, one of the things that we say as clinicians is that no 2 transplants are the same. You know, everybody's experience is different, and so also even when we do a transplant in the same person twice, you're going to get probably 2 different experiences. You know, we often use different drugs in a second transplant than we do in a first transplant. The situation is often different in that somebody has acquired some treatment from before and has perhaps had treatment in between. They might have had some more transfusions, maybe some infections. And so people don't remain in steady state from one transplant to the next necessarily either. And, you know, doing more than one transplant. Doing one transplant is tricky. Doing more than one transplant can be more difficult. And depending on the reason for doing a second transplant, we might kind of shift the emphasis of the treatment slightly to kind of, you know, possibly create a little bit more graft versus host disease, or start weaning immunosuppression a little bit earlier for some people. So we might even be artificially generating a different experience to get the result that we need and want from that transplant for the outcome to be successful.
Yeah, so there can be lots of tweaking done on the process in individual cases. So.
Yeah.
I'm gonna try again, Stephen. Any joy? No. The other suggestion I have, Stephen, is could you come in on your phone? Could you just join on your phone, or? Might be an idea. He's going to try and join on his phone. I feel terrible. I especially asked him to come along. Has anyone? I think we've exhausted a lot of the questions in the chat box and the questions that were on the registration forms. Let me just see. Oh, someone had a stem cell transplant. I don't think that person's here actually. 5 years ago, had a very bad reaction to the Pfizer vaccine, and has been advised not to continue with vaccines or the flu jab, and so that's obviously making it very sort of apprehensive for somebody about the winter. And the other thing that I've noticed, you've probably all heard about the autumn booster campaign, and the new vaccines on the market called a bivalent one, which is supposed to be helpful for both the Delta variant and Omicron. But somebody kindly pointed out that the data on the patient information sheet is that the vaccine hasn't been tested on immunosuppressed people, and it also says, and it may not work in immunosuppressed people. So I think we're going to have to seek advice on that. I don't know if you've heard anything about that, Victoria.
I mean, it's a difficult one because the caveat for all vaccines is that they may not work in immunosuppressed people.
And none of them are tested on immunosuppressed people either, are they? So
yeah. So there's been a quite large study in the UK called the Octave study, which is testing vaccine responses in cancer patients. Now, we don't know the results of that yet, but that will actually kind of give us some information about these COVID vaccines in people who are having cancer, and it's also including kind of other immunosuppressed people. So when that's available, that may, I think, be quite helpful. But it's very, very difficult to generalize. Certainly, if you are within 3 to 6 months of a transplant, the likelihood of you responding to a vaccine is quite low. That's very different if you're 5 years post-transplant. So I think we just have to kind of keep a close eye on things and try and be kind of as up-to-date as possible, and recognize that it probably remains a very dynamic and quite changing environment. And that's, you know, as I said before, that's the hardest thing about kind of actually dealing with this. You have a piece of information that's up to date today, and within, you know, a month, that information could have changed.
Mm-hmm. And I think the other news that I read yesterday was that hospitals and care homes from the 31st of August are not going to be routinely testing patients for COVID. So from the point of view of many of us who are immunosuppressed, we used to feel a hospital was quite a safe place, but now they're not sort of testing other patients. We've had stories of people, in wards where another patient has COVID, and also it says they will be testing immunosuppressed patients, and I think, well, it's not necessarily the immunosuppressed patients that are the problem. It's the problem of the other patients for immunosuppressed patients. But it also says they will test them if they're showing COVID symptoms, and then blithely say a fever, loss of taste of smell, and a cough, which are no longer the symptoms for Omicron, which are coughing, sneezing, sore throat, basically what you might think of as a bad cold or something. So I think that makes, and particularly for people who are post-transplant, who are very, very vulnerable, I think that makes things a lot more risky or a lot more worrying. So
yeah, I mean the guidance is difficult. I think there is an allowance within hospital settings to try and implement local policies, and I think that also makes it difficult because you will find that possibly sometimes different things happen in different hospitals. We try very much to go in line with transplant guidance, and that's actually quite helpful, because if we have British transplant guidance or European transplant guidance that advocates ongoing testing, that is often quite helpful in us implementing our own policy. And we can do things on haematology wards. You made the valid point, it doesn't help with the rest of the hospital in terms of what's going on there, but vast majority of our patients who are having transplants or chemotherapy would be cohorted on a haematology ward. I don't know, Michelle, if you've got anything to add to that.
Not really. It's complicated. I think what we want to do is to enable people to be as well protected as they possibly can. So having the vaccination, and as we operate a vaccination model post-transplant, regardless of whether somebody has had a transplant using their own cells or transplant using somebody else's cells, but also to be normally cautious about infections, and particularly during the early years after the transplant, we're always happy to hear from people if they're running into problems with infections, and that can often lead to an admission to King's. Not everybody wants to come back here to have infections managed, particularly if they are a number of years out post-transplant, but we can often help. We can certainly help to triage people and help them make the right decisions around where to seek help should they run into problems, and also we're still using masks within haematology in all our clinical areas to enable people to feel safer, and also to protect patients from us as health professionals as well, by providing that barrier.
Yeah, I think certainly, what did they say? There's 500,000 immunosuppressed patients who are getting quite anxious. I think, Stephen, are you on your phone? Can we hear you?
I'm on my phone.
Hooray! I think you're actually, this is typical of you, isn't it? I think you're actually probably going to get the last word here, but can you tell us about your stem cell experiences?
Yeah, I mean, I had a curious experience because I was diagnosed in late 2019 with 0 symptoms, and a blood test randomly threw up that I had relatively low neutrophils. And anyway, to cut a long story short, I followed it up and had a bone marrow test which showed that I had very high percentage of blasts. It was MDS EB2, and I was at this stage I was already in my 70s. I went to King's, and they lined me up for a transplant. They found a 12 out of 12 donor, for which I was extremely lucky. And I was lined up to have my transplant in late 2020, and then COVID hit, and it all got put back. And so I was on azacitidine I was on azacitidine and venetoclax initially to get rid of the blasts, and then I had to be on azacitidine to maintain me while I was being lined up for the transplant. I was admitted to King's on March the 31st last year, kicked out on April the 1st, April Fool's Day, because I had adenovirus. So I then had to wait for about 5 or 6 weeks for that to clear up. And I went in on May the 5th last year, had the transplant on May the 12th, and I was out of hospital 2 weeks later. So I was only in hospital for a total of 3 weeks. I have to say, I think I've been incredibly lucky. I'm trying to find bits of wood to touch. I mean, I had admissions to hospital twice with infections and sepsis before my transplant. I had a week in hospital this time last year with sepsis again, which turned out to be because my central line had been left in for too long. So once that was out, I was fine. And since then, I mean, I've had mild graft versus host disease, and they're still following me up in various ways with clinics to check my lungs and to check my gastrointestinal tract and so on. But touch wood, apart from feeling a bit more tired, I've been pretty good, actually. I mean, I've probably lost more weight than I wanted to lose. Losing a few kilos was good. I've lost about 10 kilos since before the transplant, which is probably a little bit more than I would like to have lost. But anyway, apart from that, touch wood and crossing fingers, I seem to have come through pretty well so far. I've been 100% remission the last test that I had. So long may that continue, and many thanks to King's.
Yeah. Well, on that upbeat note, thank you very much. I think the stem cell transplant diet is not one that most people would recommend. I think just go for the Mediterranean if you can. Oh dear. So Victoria and Michelle, is there anything you would like to sort of say to wind up? We're just on time to finish. So.
No, I think we've covered an enormous amount of very wide-ranging topics, actually. It's been a great meeting, I have to say, really kind of well organized, and lots of kind of, amazing insights from people. The transplant journey is different for everybody. So thanks everyone for coming. It's nice to see you all, and nice to see a few familiar King's faces amongst you as well.
Thank you. Michelle.
Yeah, thank you so much. It's been nice to join even just for a short while. So thank you very much. And great to hear the patient stories, because at the end of the day, you are what we are all about. And so we learn from you as well, which is great. Thank you so much.
Yeah, thank you both so much for coming. This meeting has been, really sought after for a long time by a lot of our patients. So I hope you all feel that you've learned something today, that you're encouraged, you have a better understanding of what may lie ahead. And thank you to all the people who've had a transplant, who've been willing to share their experiences. So thank you, all of you. Do come along to any of our other meetings. They won't be as big as this one, I can guarantee that. But it's lovely to see so many people here. So thank you, all of you, for coming. All right, bye.